Klaus, a wonderful scene of the river. It's really amazing.
Yeah, but it's summertime, and if you look out of the window now, it's really rainy. We had a heavy autumn storm with a lot of strong wind tonight. So it's the opposite today, to be honest. I hardly can see the river from my office. Usually you can see the city very well.
We don't need that much detail. This is enough for us.
We have weather. We have a very beautiful weather here in Strasbourg. I can see the mountains from my, yeah, so that's good.
Strasbourg must be far away, Ariel.
Sorry?
Strasbourg must be far away from Heidelberg.
Yeah.
Yes.
Steffi, I think it's 2 o'clock. Shall we start?
Yes, I would say that we start this.
Okay, this is the official start of the ERCnet ESPN workshop Fundamentals in Pediatric Dialysis. I have the great pleasure to welcome you to a session which extends over 2 afternoons, 4 sessions with 2 sessions per day. Each session consists of 3 talks followed by a combined discussion of all 3 speakers. We welcome you to ask questions in the question box on the screen, and please ask questions so that we have a lot of things to discuss. At the end of each afternoon, there is a challenging case session for panel discussion. Unfortunately, so far we have only 2 cases, so please consider submitting cases still today or tomorrow. Just a simple slide or just asking questions. What is interesting for you? What should be discussed? What don't you understand after the talk of the afternoon? So it should be a sort of vivid discussion and not just presentation of data. For those of you who have not registered for more than 1 talk, because obviously there have been more registrations for the first talk than for the others, please keep in mind that you have to register for each talk independently. You can do this here in the chat box or on the ERCnet website. Please choose all the presentations you want to attend. Yeah, and then I think let's start. I don't think I need to introduce myself, so I will start right away with my talk. That is on principles of chronic peritoneal dialysis, on the machines and the dialysates and the catheters. PD is rather a simple technique with infusion of PD fluid while recycling to the peritoneal cavity and drainage after 60 to 90 minutes overnight. But of course, the devil is in the details. The peritoneal dialysis, as compared to the healthy kidney, has major limitations, which you are probably all aware of. There's only some 10 to 15% removal of small solutes and toxins as compared to the kidney. There's less removal of the middle molecules, even less than for the small toxins. There's no removal of protein-bound toxins, which accumulate in CKD. There's some protein loss with the dialysate, also of protein-bound toxins, but that's a low clearance rate. And there's no tubular reabsorption as it is in the kidney, which is, for example, relevant in infants with high sodium chloride losses. I will come to that later. The structure of the PD membrane is not that complicated. You have the mesothelial cell layer, the interstitium, the capillaries, and the lymphatics. If you go to tissue stains of the peritoneum, and these are healthy children, you can see a very nice three-layer structure of the peritoneum containing the blood vessels, the lymphatics, and the nerves. And you can calculate age-dependent changes in the blood capillary density, in the thickness, in the lymphatic vessel density. I would like to draw your attention to a simple fact that the infants and the very young children have a much higher blood capillary density with a wide variation of the blood capillary density as compared to older children. This is functionally relevant. This, for example, explains to some extent why young children and infants need higher glucose concentration for ultrafiltration. The glucose is much more rapidly absorbed. The peritoneal membrane function has been described by complex and refined mathematical models, and at the end they came up with a 3-pore model, indeed very well predicting peritoneal membrane function. The 3-pore model consists of the ultra small pores, which are actually aquaporin 1 channels, so we know the correlate for this pore, and that is responsible for 40 to 50% of ultrafiltration. Then there are the small pores. They are responsible for water and also solid and toxin transfer. 50 to 60% of total ultrafiltration is exerted via the small pores. And then there are a few large pores which transfer large molecules and which are responsible for the leakage. But please keep in mind that this is just a mathematical model. The reality is much more complex. There's transcellular transport across different channels, active and passive channels, and there's the paracellular transport across a complex system of junctions, of which we do not really know the practical function in PD and the consequence for the patient. So there's a lot of space for research. But now coming back to the peritoneal membrane function, I just told you ultrafiltration is mainly via aquaporin 1 and up via the small pores, but there's also considerable fluid reabsorption into the interstitial space via the capillaries and the lymphatics. This is relevant and is dependent also on the intra-abdominal pressure. So if you have a high volume, you have a higher fluid reabsorption. And then there's the solid removal via the small pores and a little bit via the large pores. These findings are individually very different. So you can have patients with a very slow transport and other patients with a large, rapid transport from the very beginning of PD. And this is driven by genetic differences and by PD-related changes in the peritoneal membrane. As I just told you, the intraperitoneal pressure is of relevance, especially for fluid reabsorption and peritoneal area in contact with dialysate. With the usual dwell volume, only 50% of the peritoneum are wetted, are in contact with dialysate fluid, so the dwell volume plays a major role, and Ariane will talk about that later. Let's go a little bit more in detail, because these are the clinically relevant points. The fluid transport, the water transport, and the dissolved solutes depend on the glucose concentration. The higher the glucose concentration, the more ultrafiltration you achieve. But it also depends on the osmotic conductance of glucose, that is the capacity of glucose to remove fluid. And this is, for example, reduced with peritoneal fibrosis. I will talk about that later. And another very important fact is that during the early phase of a dwell, during the first 60 minutes, You have mainly free water transport. So this is aquaporin 1 driven, only water is removed, which results in a transient decline in dialysate solute concentration. And usually, at least in adult medicine, you can measure and is measured the so-called sodium sieving. That is the decline of the sodium dialysate concentration during the first 60 minutes of the dwell at minute 60, ranging from 6 to 11 millimole per liter. Later in the dwell, the small pore function predominates, so the concentration of the solutes increases again. This means that when you have short dwells with high glucose concentration, so a lot of free water transport across aquaporin 1, this may result in a relative increase in the sodium concentration in the blood, and this can cause thirst. So it's not reasonable just to have, over a long period of time, short dwells with high glucose concentrations. You remove more free water than solutes, and especially sodium chloride. How about the sodium transport? This is driven by the concentration gradient. So it's diffusion, or let's say osmosis, across the semi-permeable peritoneal membrane, and also by a so-called convection. That is the removal of solutes dragged together with the ultrafiltration. And that's another very important point. Infants require a lot of ultrafiltration because the relative fluid turnover as compared to older children is higher. And so you need high amounts of ultrafiltration, and the patient can run into a sodium chloride deficiency. So what you need to do, you measure the sodium chloride concentration in the dialysate. Usually it's about 100 to 130, depends on the dwell time. And this amount of sodium concentration per liter is what you lose per liter ultrafiltration. If you have a newborn or an infant with low blood pressure, it is very likely that you have to remove too much sodium chloride with ultrafiltration. The same holds true for calcium losses. You lose about 1.25 millimole per liters of calcium with liter of ultrafiltration. And keeping in mind that young children and pubertal children are rapidly growing and need positive calcium balance, this explains why you need, for example, a high calcium concentration in dialysate, or to some extent calcium-containing phosphate binders. So these are critically important facts. The protein loss and macromolecule loss is not that clinically relevant. One important thing is, and there's a lot of debate in the literature, but again, it's clear the function is primarily driven by the peritoneal vessel density, and this is data from a recent study showing that indeed the higher the peritoneal vessel density, the higher the D over P creatinine ratio in the PET test, and the lower the D over D zero glucose concentration. So the more the vessels, the more rapid sodium transport, but also higher needs of glucose concentration. And this microvessel density independently predicts peritoneal membrane function. This is relevant for the PD membrane transformation I will talk about later. But at first, I would like to present you the SONG initiative, a wonderful initiative, a worldwide iterative approach to understand what are the core outcomes that should be cited and studied in every clinical trial. And this has been decided by patient, caregivers, and the healthcare professional together. And as you can see, this is PD infection, cardiovascular disease, mortality, PD failure, and life participation. These are the most important clinical outcome parameter. And all of them also depend on PD fluid biocompatibility, on the efficiency and sustainability of PD fluids. So we have to talk quite a bit about PD fluids. There are two different types. They're so-called high GDP fluids. They are single chamber fluids. And during the heat sterilization process, the glucose transforms to some extent to glucose degradation products. And with prolonged storage, this continues. And you can see that you get a yellowish color of the PD fluid. When you separate the glucose at a very low pH from the buffer solution, this does not occur, or only to a very small extent. So what are the components of PD fluids? There are the electrolytes. You don't want to lose too many. Sodium chloride, calcium. You can even have the high calcium concentrations for growth and bone growth. Magnesium, and very high concentrations of glucose with a very high osmolarity of the dialysis solution. 1.5% means 1,500 milligram per deciliter. So we induce a severe diabetic condition into the peritoneal cavity. And if you use 4.25%, this is very high, very toxic. Usually you are not able to do this for more than 7 weeks or a few months. This destroys the peritoneum. Then the solutions contain lactate at high concentration. The blood concentration of lactate is 1 millimole, so that's also high. This also confers toxicity. And the pH in this solution is very low, 5.5, really acidic. And then there are 3 different GDPs listed: formaldehyde, 3-DG, and 3,4-DGE. This one, the latter one, is a real toxic one. And the total exposure and absorption sums up to several grams per year. So we infuse toxic substances into the patient. That's why everybody should, as long as possible, use this low GDP fluids, the biocompatible double chamber solutions. But they still have the high glucose concentration, the high osmolarity. Some of them still have lactate, and they are much less GDPs, but they are not GDP free. The only solution that is GDP free, I will talk later about this, is the amino acid solution. And all these solutions can use a lot of local peritoneal membranes with transformation of the PD membrane. And I've shown you this slide before, but the truth is, after only 2 years of PD, unless it was a young infant, actually a baby, after 2 years of PD, you see massive angiogenesis. And I told you the vessel density drives the PD membrane function. And after a long period of PD, 9 years, you see major fibrosis. And you can summarize this in nice schemas with very early rapid blood vessel formation and vasculopathy ongoing and fibrosis. The message at the end for you is that in fluids with low GDP concentration, they are still toxic, and the driving force is the dialysate glucose, a very high concentration of glucose. That means for the clinical situation, use the lowest glucose concentration possible. Advise the patients to have a low sodium intake, because this drives the fluid overload, except for the infants that I told you. So this is critically important to preserve the PD membrane. Then I just alluded to the fact that there are other fluids, the icodextrin fluid. This fluid contains icodextrin, different molecular size, 1.7 to 45 kilodalton. It's slowly absorbed, only 40 to 50% are absorbed after 12 hours. The absorption is more rapid in infants and young children. The effect may be less beneficial, but overall you have a sustained ultrafiltration, aquaporin 1 independent, so there's no sodium sieving, no free water loss. The ultrafiltration is less dependent on the peritoneal transporter status, no GDP content. And it's just to exemplify steady increase in the intraperitoneal volume and net ultrafiltration. While with glucose, this is absorbed, you have loss of ultrafiltration with long dwells. So uniquely suited for the long daytime dweller in cycling PD. And as a matter of fact, a number of studies of randomized control trials have shown that you indeed improve the overall ultrafiltration capacity, that you have fewer episodes of fluid overload, and in adult patients, there's also a decreased mortality risk. So this is a major progress, and in patients where you have fluid overload with low residuary and functional low urine output, consider icodextrin. Amino acid solutions, they don't contain glucose, no GDP, they have similar solvents in water transport. They don't contain phosphate but provide amino acids. And there is in adults some increase in protein synthesis rate when you use 1 gel per day, the amino acid solution. But the nutritional effect appears small, especially if you compare it to GI feeding and tube feeding. The costs are considerable, and the biocompatibility is uncertain. It's not yet really known. And the indication in pediatric dialysis remains uncertain. I don't really use it in the past, and I'm not aware of any other centers using it. Now let's come to the catheters. There are the pediatric Swanneck catheters and the straight catheters. We rather go for straight catheters, but we bow them a little bit to the side. And of course, you need the extension line. And now just a few important statements. on the catheter choice and placement. The catheter length and the curl size depend on the body length. The catheter length is from 31 to 62.5 centimeters, and there are usually two different curl sizes for the small children and the larger children. Use catheter with screw cuffs. They fix the catheter and they are a barrier for infection. Estimate the cuff position from the distance between the umbilicus and the symphysis pubis. Go for a downward or lateral subcutaneous tunnel exit site. It has been clearly shown that you have less infections with this direction of the exit. And in infants, keep in mind that the exit should be above the diaper area, otherwise you will have infections of the exit side and of the tunnel, and distant from the gastrostomies, because there are also quite frequent infections, and there are also sometimes fungal infections of the gastrostomy, which poses the risk of peritoneal infection, peritonitis with fungus. The insertion can be performed laparoscopically with the curled portion positioned deep in the pelvis. Administer first-generation cephalosporin, such as cefazolin, just prior to surgery. In patients with Staph aureus carrier, consider a glycopeptide, vancomycin or teicoplanin, and perform omentomectomy, especially in the young children. But overall, really talk to the surgeon, consider omentomectomy, because it has been shown to prevent obstruction of the catheter. And what is usually done is that a doctor or nurse checks the catheter function in the operation center, looks for dialysate leaks, infusing 10 to 20 centiliter per kilogram body weight to verify adequate function and absence of leakage. Now, last but not least, coming to the machines. The machines are actually not existing for newborns and young infants. That's a manual approach. You have the burettes, and you have the manual exchange with the bags over here and the effluent bag down here, and that you need a heating system to prevent cooling of the patient. And this is a very bad example. You have to take care that the burette is not too low. These are communicating systems. And if you have here 80 centimeters or even 1 meter of distance between the patient and the burette, this causes a lot of suction and may result in obstruction of the catheter and a lot of abdominal pain with suction of the peritoneum into the pores of the catheter. Then, especially in preterm babies, in newborns, minimize the death space, shorten the catheter and shorten the extension. Use manual burette system until you have a dwell volume of 80 to 100 milliliter dwell volume. From that volume on, you can consider to switch to cycles. And that's for good reason, less work. And the modern cycles allow for low inflow rates and outflow rates, and the pressure exerted is often much lower than what we do with our manual infusion and our manual outflow of the dialysate with a lot of suction. There are different types of cycles on the market, and I'm sure Ariane will talk about the PD regimen, what you can all do with these cycles. And this is beyond the topic of this talk, but I want to draw your attention to the fact that the modern cycles now come up with thought of remote monitoring devices. For example, here this is a shared source device where you can really closely monitor online the performance, the alarms, red flag alarms that you decide about, and you can better control and interact with the patient. And I think this is really something for the future. On the patient side, we can monitor PD clearance, ultrafiltration. The patient can give us the blood pressure, and if there's a problem, we can timely intervene with identification of the problems. And of course, reduce the burden of the patients when there's external responsibility online. And we can modify a lot of things, and we can, with video devices, and of course we all have mobiles now, exit sites, core fluid status, etc., can be monitored. And at the end, this is really good for the PD center, better control, probably less follow-ups in the center, but of course you also have some duties. We have to set the individual red flag system. We have to decide when do we monitor the big amount of data. We have to check the system is working fine, but we can also do then longitudinal data analysis and have a more wide-scale big data set at the end, which will give us other interesting information. But that's the topic, and I'm already at the end of my talk and would like to come up with my question. I assume will sneak in so that you can give your answers. I have here 5 questions related to PD-related statements. Which PD-related statements are right? So the first one is, next to diffusion across the protein membrane, osmosis, convection contributes to purification. Is this right or not? I'm not sure, Steffi, whether I will.
Klaus, then I have a different. So I included a question, but like so that people can choose one of them. So then I understood it wrong. I will.
So, okay, then. So which one of the questions is right? So is the first question right? So we ask the people whether the first question is right. So we go to the next one. Is low GDP fluids hardly transform the peritoneal membrane? Is that right or wrong? Icodextrin fluids improve salt and water removal during the long dwell. Aumenticity is required in selected patients only. UF-associated electrolyte losses can be estimated from the effluent concentration. So which of the statement is wrong? So we just turn it the other way around.
Okay, then I will start now and people have to choose which one of them is wrong. So we wait another 30 seconds. Okay, Klaus, can you see the answers?
I can't see the answer now.
Okay, so 38% of the attendees thought that the 4th question is wrong. Then 28% of the attendees thought the 2nd one is wrong. So low GDP fluids hardly transform the peritoneal membrane. Then 80% thought the 3rd question is wrong, or the 3rd option is wrong, and the other one were less. So maybe you
so the truth is, I mean, that was a little bit confusing, honestly. So we didn't communicate well. I'm sorry for that. The question was which of the PD statements so they are right. So it's several statements, but the 2nd one is wrong. Of course, I've shown that the GDP fluids transform the peritoneal membrane very much. So this is still a major problem. This is due to the glucose concentration. And of course, the 4th one is wrong. We need aumentectomy in most of the patients. So that is the end of the talk. And for the sake of the time, I would really encourage all of you to ask questions in the online chat. I don't see any questions so far. So please, probably that was very fast. Some of the things are not clear for you. Please ask questions so we can clarify them at the end of the session. And then I have the pleasure to introduce Ariane Salosik from Strasbourg. She's the head of pediatric nephrology from a renowned pediatric nephrology center, who actually developed many very innovative measures in hemodialysis and peritoneal dialysis in children. And who could better talk about PD regimen than the doctor who was inventing together with Michel Fischbach the adapted PD regimen and other very innovative things. Ariane, it's my great pleasure. Please give your talk.
Thank you very much, Klaus. Do you see my screen?
Yes.
Okay, thank you. So I'm Ariane Salosik, and I'm going to speak about management of PD, if it works. So In order to prescribe a good PD, we need to establish 3 parameters according to patient specificity and acceptability. Sorry, I have some problem with the PowerPoint. It doesn't work. So first, we have to prescribe the PD fluid, the most biocompatible being the better, probably. Secondly, the dwell time. If we prescribe a short dwell time, we will have a conservation of ultrafiltration due to the osmotic gradient. In case of prescription of a long dwell time, we will have a better purification, but a loss of osmotic gradient. Thirdly, we have to prescribe the IPV volume. If we prescribe a large IPV volume, we will recruit more peritoneal membrane surface, and it will allow for a better purification. But if the fill volume is too large, we will have a discomfort for the patient, and we will have a loss of UF due to the back filtration. Having that in mind, we then have to choose between CAPD, so continuous ambulatory PD, or automated PD. This one is probably the best option for children. It's performed with a cycler during the night. Continuous ambulatory PD is performed during day, manually operated. So we are going to focus on APD. The most common prescription is IPD for intermittent PD, consisting of a repetition of identical cycle during the night. If we add a day dwell, we have continuous cyclic PD, so CCPD. We can also add an extra cycle late afternoon or early in the evening, and that's DP+, or perform tidal PD. We are not going to have a full drain after each cycle. Or the last option is to prescribe adapted PD. It is supposed to allow for a better purification, a better ultrafiltration and sodium removal, and it consists of a variation of prescription of dwell volume and duration during the night. And of course, you have an infinity of possibilities, because we can, for example, prescribe AAPD, so adapted PD, with a day dwell or with DP+, and so on. Let's talk about the first PD prescription. If possible, we should try not to use the catheter just after the insertion, but it's not always possible in case of acute PD. As for the volumes, we are going to try to start with low volume, 10 milliliter per kilo, and proceed to a progressive increase. And we try to obtain at the end a volume of 1.2 to 1.4 liter per square meters in children older than 2 years of age, and a volume of 0.8 to 0.9 liter per square meter in children younger than 2 years. And IPD is possible if the patient still has residual urine, but it's also very usual to prescribe CCPD with the volume of the day being the half Phi volume of the night. Concerning the number of exchanges, the number of exchanges depends on the needs of the patient. We usually prescribe between 5 to 15 cycles per patient. At the beginning of PD, the patient can require PD 20 hours a day. Concerning dwell time, the most usual dwell time prescribed is 1 hour, but in infants, we sometimes decrease this time to 20 minutes to 30 minutes, or in case of major overhydration, if we need a rapid ultrafiltration. Depending on the tips, PD can be started with manual exchanges or with a cycler, but for children with a low weight, if we need small volumes, the most usual prescription is to start with these burette systems, and we cannot prescribe volumes under 100 milliliter with a cycler. Then we have to adapt our prescription. We are trying to have the best fill volume for allowing tolerance, UF and membrane recruitment, and the best wait time allowing for purification without a too high loss of ultrafiltration. So if the patient needs more dialysis dose, the usual adaptive strategy is to increase the total amount of fill volume, and it can be by increasing each fill volume if IPP is acceptable, or to increase duration of overnight cycles, or to add a day dwell, or to perform DP+. If an increase of UF is necessary, or in case of bad sodium or volume control, we can prescribe shorter cycle, but it will help for the ultrafiltration, but not for sodium removal. We can add a day dwell with high codextrin, allowing for a delayed ultrafiltration, or we can prescribe adapted APD. We are going to talk about this later, or use a higher glucose content solution, but it's not the best solution in terms of membrane preservation. We have tools helping for this prescription. For example, for IP fill volume, we have the intraperitoneal pressure measurement, IPPM. IPP can be used to determine the individual capacity of peritoneal surface recruitment. If the patient is presenting with a low fill volume and a high IPP and needs purification, PD will be hard to maintain. So IPPM is a very easy procedure, as you can see in this movie. So after the patient went to the toilet, he must lie at rest. Zero level is done on the medial axillary line, like that. Connection to patient is open. And we only have to read the scales, the centimeter on the scales, and the IPP measurement is the mean value between the inspiratory and expiratory pressure. IPP is correlated to the IPV, to the intraperitoneal volume. The higher the volume you infuse, the higher will be the IPP until a plateau. In children, we try to obtain an IPP under 12 to 14 centimeters of water. In infants, an IPP under 8 to 10 centimeters of water. And we try to never exceed 18 centimeters of water. Why is IPP relevant for our clinical practice? An increased IPP is correlated with mechanical complication, and as you know, 6.6% of pediatric PD patients develop hernia and leakage. The risk factors increasing these mechanical complications are the same, increasing the IPP, organomegaly, adhesions, constipation, malnutrition, surgery, or pain. Increased IPP will also reduce the ultrafiltration due to backfiltration and transport. It will also induce a bad tolerance for patients when the IPP is over 18 centimeters of water. We also know that the tolerance is better in supine position, so we can have a higher volume of fluid during the night. And an increased IPP was related to an increased number of peritonitis. So more interestingly, it was also linked to mortality and switch to HD in this study from Uterello. And as you can see, it was the only factor predictive of death or switch to HD in a multivariate analysis. Another tool can be used to this time determine the dwell time. So it's peritoneal equilibration test. It can be useful for the dwell time, but also to know how well the membrane works. In patients with high or low transport status, dialysis can be difficult to achieve. So in clinical practice, to perform a peritoneal equilibration test, we are going to infuse 1.1 liter per square meters of a hypertonic solution in our patient and collect dialysate at the beginning, 30 minutes, 1 hour, 2 hours, 3 hours, and 4 hours of time, and collect blood at the beginning, the middle, and at the end of the test. For urea and creatinine, we will obtain this kind of graphic calculated as the dialysate to plasma ratio. And for glucose, we use this kind of graphic, each time being divided by the concentration at the beginning in the dialysate. According to this peritoneal equilibration test, we are going to have 4 kinds of transporters among our patients. So the patient with a high transport status, we have 10% of our patients with this status. They have a rapid solute transport and a reduced UF due to the rapid absorption of glucose. They require short dwell. Then we have the high average patient, 53% of our patient, a low average patient, 31%, and the patient with a low transport status. They have a very slow solute transport. The clearance targets can be difficult to achieve, and they need long dwell. So for those patients with a high transport status, APD is better than CAPD because they require short dwell. Another parameter can be assessed with our peritoneal equilibration test. That's the apex time. It is the cross point between the urea saturation curve and the glucose desaturation curve. And this time can be used as the dwell time. Why are peritoneal equilibration tests relevant? It was linked to an increased mortality for the patient with a high average and high transport status in a big study in the United States. And a very similar result was found in New Zealand and Australia, where the patient with a high transport status were found to have an increased mortality. But just take note that those patients were receiving CAPD treatment, so with a long dwell. In children, the patient with high transport status were found to have a decreased longitudinal growth. So now, how to make the follow-up of our patient? We have to assess the adequacy of our treatment, to make sure that the blood pressure is good, that the patient have a good hydration status, that the dose is okay. We also check electrolytes, phosphate and calcium balance, creatinine clearance, KT over V. IPP can be performed every 3 months or if you need to increase the volume. Peritoneal equilibration test should be done 1 month after the beginning of the treatment and every year, or if you are facing a problem with the prescription. And that's the typical prescription in Strasbourg of the monthly follow-up of our patient. We are going to check the impedance metry, the IPP, the volume of urine, the exit score, and so on. So a few words about AIPD. That's a new concept described by Professor Fischbach. It is supposed to allow for a better sodium and water removal. So it consists of a variation of the cycle. So a sequence of short cycle with low field volume is followed by a long cycle with high field volume, but we use the same total amount of fluid and the same total duration as in standard APD. How does it work? We only have hypotheses. To make a long story short, the small and short cycle favors the aquaporine mediated UF, that is to say the free water UF. This free water in the short cycle is only partially drained by the gravity. In fact, the IPP will be low because the volume is small. As a consequence, the concentration of the next cycle will be decreased by dilution due to this residual UF. Moreover, the UF of free water may lead to a hemoconcentration, measuring the plasma sodium concentration and the gradient to the fluid. The large and long cycle will allow the diffusion to take place and to recruit small pores. So we will have an impact from the first exchange on the second. In clinical routine, how to prescribe AAPD? It's easy. For the short well, we are going to use the peritoneal equilibration test. I use the apex time to determine the time of this first cycle. The second cycle is 3 times longer than the first one. For the volume, we are going to use the small volume is the half volume of the large one. And the maximal IPP has to be 14 to 15, the volume of the large cycle being 1.4 liter to 1.5 liter. So now I'm at the end of my presentation. Sorry, because I had some issue with the change in the slide. Bye.
So thank you very much, Ariane, for this wonderful overview. We're going to discuss the questions at the end of the session, and I'm delighted to introduce Sehcan Bakaloglu from Ankara, the Turkish. He runs a huge pediatric department, has enormous experience with dialysis in children, is a member of many guideline groups, and has contributed many guidelines regarding dialysis in children, especially with a focus on peritonitis and other complications of peritoneal dialysis in children. Please, Sehcan.
Thank you, Klaus, for your nice work. Thanks to organizer. It's my pleasure to present you main complications of peritoneal dialysis in children today. PD is the most widely prevalent dialysis modality for children. During the last few years, there are some papers, registry data showing that hemodialysis has been increasingly used in children, particularly in adolescents. In this ESPN ERA-EDTA registry data, we clearly see that PD and HD are equally utilized, children less than 15 years old. But when we consider little kids, less than 20 kilograms, USRDS data clearly showed that PD is the preferred modality of dialytic treatment choice. Peritoneal good functioning PD catheter and its longevity has some threats like infectious and non-infectious complications. I will mainly focus on infectious complications and mechanical catheter dysfunction today. Despite technological advances in connectology and new biocompatible PD solutions and development of quality assurance programs, peritonitis remains the most common complication of CPD, chronic peritoneal dialysis. There are many international or large national or small national registries collecting data on demographics, mortality, and also peritonitis and mechanical dysfunctions. We can reach those ones here, and all those registry data and some randomized trials clearly show that, or some pediatric clinical trials, retrospective studies clearly show that peritonitis rate is decreasing over years. Lowest ratios are coming from Japan, even in 2002, but in North America, after SCOPE collaborative, there is a significant decrease in peritonitis rate. Peritonitis causes not only hospitalization, catheter loss, it's a significant cause of death in children. That's why when we have an infectious episode, we should treat this episode appropriately by using guideline recommendations, but more importantly, prevention of peritonitis should be the top priority goal of every PD setting, every PD program. That's why we need to give more attention to them to prevent peritonitis to achieve optimal outcome. There are several elements of prevention of peritonitis. One is related to catheter interventions. We generally most commonly use double cuff catheters and lateral subcutaneous tunnel configuration for optimal functioning and less peritonitis episodes. There are several other catheter designs, straight versus coiled catheters, single versus double cuff, Swan neck or straight tunnel. There are several different implantation techniques, including blind percutaneous placement, open surgical or laparoscopic. There are different catheter designs, which is shown in here, but there is no firm agreement on exact catheter type and configuration, and there is no technique of PD catheter implementation to have proven to be superior for preventing peritonitis. The most important thing is PD catheter size. We should best fitted size catheter to the patient size, and center surgical experience in the applied technique is another important area. Which technique is best provided, best done, best performed in that center, we should take this implantation technique. There are some good clinical practice recommendations here. Location of superficial cuff 2 cm from the exit site, smallest exit site hole, no incision, no sutures at the exit site. Catheter anchoring and immobilization important. Dressing chains should be avoided in the first week, if possible up to 6 weeks. If possible, don't use the catheter at least for 2 weeks. These are the best practice, good practice recommendations. What about the antimicrobial prophylaxis? We should give first generation cephalosporin or vancomycin at catheter insertion. If MRSA emethicillin resistance rate is high in the center, vancomycin may be preferred, but we don't want any vancomycin resistance for future peritonitis treatments. That's why first generation cephalosporins are preferable. What about exit site cleaning? There are several cleansing solutions and also topical antimicrobials for exit site infection prevention, for prevention colonization. Mupirocin or gentamicin, most widely used ones. In IPPR database, it's shown that saline or soap for cleansing, exit site care more than twice per week, and use of exit site mupirocin is associated with Pseudomonas peritonitis. On the contrary, in the adult literature, they are in the adult guideline, they are still recommending daily exit site care by using mupirocin or gentamicin, and they didn't see mupirocin resistance with daily use, but with intermittent use, resistance may be more probable. And the third element is contamination prevention. Experienced nursing personnel and long training, retraining, home visits are very important in that, but other important thing is preventing contamination. In the 70% of peritonitis episodes, we don't know the reason, we don't know the cause. If we know the cause, touch contamination is the leading one. And because of that, when we have a touch contamination case, we need to follow this algorithm. If clamp on transfer set is closed, we don't need to use antibiotics. Sterile tubing change is enough. But if a clamp is open and we instill the water to the patient, we need to change sterile tubing, and also we should start prophylactic antibiotics. And the fourth element is development of continuous quality improvement programs, tracking, questioning each episode's root cause analysis, monthly meetings, re-evaluation of protocols. The best example of this continuous quality improvement program is SCOPE Collaborative Standardized Care to Improve Outcomes in Pediatric End-Stage Kidney Disease. It's an important quality transformation network which is evaluating results of implementing standardized care for PD catheter care, and their final result is a very significant reduction in peritonitis rate. We can understand that if we adhere to the best care practice, we can decrease our peritonitis. When a patient comes to us with cloud effluent, abdominal pain or fever, we should suspect of peritonitis. We need to make a cell count, differential count, and culture. Cell count should be higher than 100, and more than half of them should be neutrophils. We have to centrifuge large amount of effluent, preferentially 50 milliliter tubes, and then sediment should go into a blood culture bottle. This should be the standard of culturing methodology. It's not like this. And when we look at the causative organisms, gram-positives are the leading agents, and among them, coagulase negative stuffs are leading, but they are slightly higher than Staph aureus, than E. coli, Streptococci, and Pseudomonas are coming. There are significant geographic variability with different reasons. To diagnose and treat our patients, we have a pediatric guideline and several adult guidelines. A new guideline is coming to the public next year, I believe. We should start empiric antibiotics, and if there is not a higher MRSA colonization, monotherapy with cefepime is a wise option. But if methicillin resistance is high in the center, we should add vancomycin, or we should start vancomycin-based combination treatment. If cefepime is not available, we can give either first-generation cephalosporin or glycopeptide for gram-positive coverage, and for gram-negative coverage, we can use ceftazidime or aminoglycoside. These are the antibiotics, and they are recommended doses for continuous and intermittent use. When culture results became available, if gram-positive bacteria cultured, we stop gram-negative. If it is methicillin-sensitive Staph aureus, we can continue with cefazolin or cefepime. If methicillin-resistant, we need to switch to vancomycin. If it is an enterococcus, we can give ampicillin. If resistant, we can use vancomycin. If vancomycin resistant, we can use daptomycin or linezolid. These are the antibiotics, and these are the durations. Generally, in resistant Staph aureus MRSA, we should continue for 3 weeks. But if it is Streptococcus species or methicillin susceptible one, we can go 2 weeks with antibiotics. In gram-negative bacteria, we stop positive coverage. It is as third-generation cephalosporin-resistant E. coli, Proteus, and Klebsiella. We need to change the antibiotic to carbapenem or fluoroquinolone. But if it is susceptible, we can continue with cefepime, ceftazidime. If it is Pseudomonas, we can continue cefepime or ceftazidime, but we need to add a second agent as a combination therapy. These are the antibiotics, agents, and durations. Stenotrophomonas and Pseudomonas and the resistant E. coli, Klebsiella needs 3 weeks of treatment, but if they are susceptible species, and we can go with antibiotics for 2 weeks. Fungal peritonitis comprise 2 to 8% of all peritonitis episodes. prior antibiotic use is the most important risk factor. If we identify fungi, we start antifungal treatment, and early catheter removal is recommended. After catheter removal, antimycotic treatment may be administered 2 to 4 weeks following complete resolution of the symptoms. We are not using amphotericin B. We start with fluconazole for Candida, caspofungin for non-responding non-albicans Candida, voriconazole for Aspergillus. There are several different peritonitis cases, like relapsing, repeat cases, and zoonotic ones. I will mention about relapsing peritonitis, which means within 4 weeks of completion of previous peritonitis episode, if a patient have a culture, if a culture give the same same microorganism, we call it relapsing peritonitis. It has a significant risk of permanent PD failure. That's why we should give a specific attention to those infections. As a post-empiric agent, we don't use cefazolin because of high resistance levels. Sometimes we use tissue plasminogen activator. Removing the PD catheter can be necessary as soon as peritonitis is controlled by antibiotic. We can remove the catheter. Relapsing peritonitis associated with persistent or recurrent tunnel infection and a second peritonitis relapse. These are the absolute indications of catheter removal. Refractory bacterial peritonitis, which means after 5 days we didn't have a clearing in the effluent. We call these peritonitis as refractory. Fungal peritonitis, exit site tunnel infections in conjunction with peritonitis with the same organism, mainly Staphylococcus and Pseudomonas aeruginosa. We should definitely remove the catheter in those patients. There are some relative indications. Save the peritoneum, not save the catheter, must be our motto, because peritoneal cavity is very valuable. There is another issue is exit site tunnel infections. There is an objective scale for this, and if the point is 4 or greater, we think about exit site infections. 6 or greater, we think about tunnel infections with or without purulent drainage. Exit site infections are mainly driven by Staphylococcus resistant or sensitive methicillin, and staph epidermidis is the second reason. Catheter-related infections are very important because they are associated with catheter loss, threefold increased risk for catheter loss. These are the treatment recommendations. Exit site infections can be treated by oral treatment after culture results, but tunnel infections generally treated by oral intraperitoneal or intravenous routes. But however, signs of severe infections and or a history of Staphylococcus and Pseudomonas aeruginosa, we should give an empiric treatment for those risks to prevent these risks. And MRSAs, we should use IV glycopeptide. These are the antibiotics and their recommended doses for exit site infections. Now I'm moving into non-infectious complications. I will mainly focus on mechanical complications. The most common mechanical complications are inflow-outflow problems, catheter malposition, pericatheter leak, and hernia. And children under 2 years of age are at particular risk for those complications. In the recent IPPN data, it's clearly shown that less than 1 year old dysfunctional catheters are much more prevalent compared to older than 1 year old. Infants are very vulnerable for mechanical complications, and they are generally showing short catheter survival. And also mechanical catheter problems double the risk of technique failure compared to infectious causes. This is another important result. During the last 20 years, there are many papers evaluating mechanical complications. 2 of them are exclusively for infants, evaluated infants. One is from Italy, which showed 15% of cases required catheter replacement. And another one is from America. They evaluated 25 infants, but 60% of them are newborns, and that's why they have a very great removal rate, 72%. It's a huge catheter replacement rate. Inflow and outflow problems are very common ones, and constipation is a very important reason of them, which can be preventable by using laxatives, enemas. If we have an inflow or outflow problem, it may be caused by catheter occlusion, kinking, migration, malposition, internal occlusion by thrombus or fibrin, and external extraluminal catheter occlusion by omentum tubes, appendix, etc., fat appendix, etc. And in that cases, catheter-related interventions are not helpful. That's why the suggestion is using the best experienced technique in the center. We see catheter kinking, which resolved after fluoroscopic interventional procedure, and we see catheter tip migration. This is coiled catheter, and this is straight catheter. Both of them are out of the pelvis. In adults, catheter fixation to the lower abdominal wall combined with straight upward tunnel configuration and low implant position resulted in less catheter complications, but it's never trialed in children. And another reason for catheter dysfunction is omental trapping. Omentopexy or omentectomy can be a solution for this. There is a controversial data. Some studies show that 2 to 3 times reduced catheter replacement rate in patients with omentectomy, undergoing omentectomy, but other papers show that omentectomy didn't change early or late mechanical complications in children. That's why in the current practice, omentectomy decision is left for the surgeon's discretion. Pericatheter leakage is quite high in neonates, infants, because of the weak abdominal wall, low subcutaneous fat. Immediate use and omentectomy may be the facilitating factors for that. What's the prevention or what's the solution? Low volume dialysate and fibrin glue may be helpful. Hernias can be seen up to 30% of patients. High IPP, weak sites in the abdominal wall, and small age are risk factors. Prophylactic closure of processus vaginalis at PD catheter insertion is the best way to prevent and treat those of them. Right-sided hydrothorax is another complication of PD. It's related to congenital diaphragmatic defect, lymphatic drainage problems, negative intrathoracic, positive intra-abdominal pressure are the risk factors. Stop PD, small volume PD, pleurodesis, or open surgery for recurrent cases can be treatment options. The last one is the late complication of peritoneal dialysis, EPS, encapsulated peritoneal sclerosis, which is directly related to the dialysis vintage. If PD duration is higher than 5 years, incidence is 6.6%. If it is higher than 10 years, incidence of EPS is higher than 20%. That's why we don't stay a lot on peritoneal dialysis. Of course, every kid deserves a well-functioning PD catheter for optimal outcome. We should always take care of PD catheters as this little baby does, but eventually the best gift for children is a well-functioning kidney allograft. I thank you very much for your attention.
Thank you very much, Stefan, for this wonderful and comprehensive overview. We are just a little bit behind the time, so 5 minutes late, but I think that's fine. We fortunately have many questions in the chat, and The first one is probably addressed to myself, is about how many days after insertion of the catheter we can start using chronic PD catheters. So the answer, the most beneficial approach probably is, and there's quite some data around that, with insertion of the catheter and waiting for some 14 days until start of hemodialysis, you have a lower complication risk and especially less leakage. But if needed, you can start right away, just after the surgery, and start with probably a fill volume of 10 milliliters per kilogram body weight. The next question is addressed to Ariane. It regards the IPP measurement. How do you cope with children that are not able to follow your instructions, who cannot follow the expiration suggestions of the doctor? How do you do IPP measurement in young children, Ariane?
We can measure IPP in very young children. We are not doing it just after surgery or after, but it's not a problem to measure it in young children. We just have to try to have the child at rest. That's not really easy, but we manage it and we do it for each child.
Okay, there are some further questions for you, Ariane, regarding the PD prescription mode. The audience asked for what would be your general recommendation? What would be a typical dwell time for a child with a low average transporter status and a child with a high or high average transporter status? Of course, it's not an easy question, but are there any rule of thumb?
So first, for children with a high glucose transport status, what is sure is that CAPD is not a good option. We have to perform APD and to have a short dwell time, so sometimes shorter than 1 hour. It depends on the apex time we can obtain in our peritoneal equilibration test, and also we are going to adapt the prescription with regard to electrolytes and UF balance, but it can be shorter than 1 hour in those specific patients. And for the patient with a low transport time, we are also going to adapt with the clinical data. So UF is easy to obtain, and sometimes APD is then for those patients not very easy to prescribe. But for example, we can add a day dwell or a DP plus in those patients to obtain a longer dwell time, and that's it. I don't know if it's...
Then there's another question which relates to a similar topic. In patients with acute dialysis, for example, after heart surgery, so if you need a lot of ultrafiltration, what's your opinion about very short dwell time of about 30 minutes? Is that okay? Is that one way to achieve high ultrafiltration?
So in acute APD, shorter time can be helpful to have a very rapid ultrafiltration, but then you have to keep in mind that we are going to extract water, but not sodium. So after a number of cycles, after multiple cycles, we have to have an increased time in our cycles to allow for sodium removal. So it can help for a patient with a very high overhydration. If we have some if we have to be very rapid for the overhydration, but then it's not only going to help for the first exchanges, and then we have to change and adapt our strategy. I don't know if
we also have to keep in mind the time you need for the inflow and the outflow, because the total dwell time may be reduced if you have many in and outflow times. So being shorter than 30 minutes is probably not wise anymore. 30 is probably the limit. Do you agree, Ariane?
Yeah, I agree.
Okay, so one question that is for Sevcan is regarding the use. When do we use intravenous and when do we use intraperitoneal antibiotics in patients with peritonitis?
In patients with very septic situation, we may try IV antibiotics, but first option should always be IP antibiotics because absorption of antibiotics, even antifungals, are antibiotics are good for microorganisms. Maybe the clinical status, CRP levels, septic toxic appearance can be a reason, and also not well answered IP treatment can be another reason. But if we didn't get any clearance in the PD fluid after 5 days, we should remove the catheter. But for example, after 2 days, we didn't get a very good response and patients is not resolving, we may try switch to parenteral treatment, IV treatment.
And the next question goes into a similar direction. What is the effect of the antibiotic treatment on ultrafiltration? Or if we turn it a little bit more general, what happens with ultrafiltration during peritonitis? Is there any effect of the antibiotic per se?
In peritonitis, we know that peritoneal permeability is increasing, but the only study, I believe, were done by your group, Klaus, peritonitis and vancomycin usage. And I believe that all antibiotics recommended dosages are taking into account increased absorption of the antibiotics. One point is very important, that cephalosporins has neurotoxicity. If we are using 2 cephalosporins at the same time, for example, cefepime plus ceftazidime, we should be aware of neurotoxicity. It can be very severe. We may see myoclonus, consciousness, and some bizarre attitude to the patient. And in the EEG examination, we can see many sharp waves. That's why I should have a reminder for that, 2 cephalosporins at the same time, or IV plus IP ceftazidime, for example. IV plus IP cefepime, for example, has an increased risk of neurotoxicity.
Okay, thank you very much. The next question regards the use of icodextrin, and it's probably addressed to me, but if anybody of you, Ariane, etc., can also answer. And there's from Evelina the question, or the patient reported that didn't really benefit from icodextrin, had lower filtration, and they put him back on another standard supplement. And so the question is, does it always work in icodextrin in children? The answer is no, it's different from adults. There's one study, I think from Toronto, Canada, showing that the absorption of icodextrin is more rapid than in adults, especially in the infants and young children. And we tried icodextrin in a newborn where we didn't succeed to achieve ultrafiltration with high glucose dialysate solutions. And the ultrafiltration was even lower with icodextrin. So what happens is you get, with this high glucose load over time, you get a lot of vascularization of the peritoneum and very rapid absorption of glucose, but also to some extent with icodextrin. And I've shown the data that young children have more peritoneal vessels, which result in more glucose absorption, but also in more icodextrin absorption. And with the transformation of the PD membrane, and that's clinically very relevant, the positive effect of icodextrin can be diminished, and that is obviously more pronounced in children than in adults.
I agree.
You agree, all right?
Yeah, I agree.
Yeah. And then there's another very important question I think we should address. Is there any data on use of manual rigid PD catheter for acute peritoneal dialysis? I mean, we have a separate section on acute peritoneal dialysis, but that's a really important one. So maybe Ariane or Sevcan, you want to answer this question?
I'm not really evaluated it, but I saw an adult acute peritoneal dialysis guideline, I believe. I think there should be one, but not in pediatrics. Not a pediatric guideline. Is that?
Ariane, any comment from your side?
No, no further comment.
I think from the historical perspective, these rigid catheters have been used in the past, but as far as I know, the complication rate was significantly higher than with the so-called Tenkov catheter we just presented, and even for acute dialysis, unless it's a life-threatening, very special situation. Usually the standard catheters are recommended also for acute peritoneal dialysis.
Brad Vardy has a study. They were using very large NG tubes, and they were highly effective when compared to other PD catheters. And in acute setting, they also be used. Very large NG tubes, simple NG tubes, nasogastric tubes.
Yes, but probably these are soft catheters, not the rigid ones used in the past, right?
No, I think it's around 10 years before there was a study from Kansas, and they were using a large NG tubes. We also are using, if we couldn't find a single cuff catheter for a newborn, for example, we sometimes using large diameter NG tubes for a limited time, of course. If time is prolonged and infection risk is higher than cuffed catheters, of course.
Okay. And I think we come to the last questions, and of course we have to have one question on adapted APD. Ariane, the question is, what are the selection criteria for patients for adapted APD? Yeah. Which use for ultrafiltration purpose or solid clearance? What would be your selection criteria?
That's a good question, because we have a local practice. So if the patient have sodium or water, if we fail to have water and sodium removal with the classical PD program in Strasbourg, we are going to use AAPD. Some teams in France are using AAPD as the first prescription for patients. But that's not my practice, but I think it can be also proposed. The only problem with AAPD is you have to make sure that the high volume is not going to provoke a too high IPP. So you really have to make sure that the IPP is still acceptable with this high dwell volume. And in this case, AAPD can be a very good option for patients with sodium and water failure of removal.
And I think if I have it well in mind, your clinical experience with adapted APD is very good, and also from several other centers, but we never systematically studied the side effects and incidence of hernia or leakage. But overall, the clinical impression is really successful, right?
That's right.
Okay, thank you very much for the vivid discussion. We are just 5 minutes behind the time, and I will still allow the audience for 15 minutes of break to grab some coffee, and we will start again at 15:35. Thank you very much.
Thank you. Thank you. Bye.
Bye. Oh, je suis désolée que là j'entends